mild or moderate traumatic brain injury with a chest injury where the key target is the intracranial pressure management should be in the range of the CO2 and oxygen partial pressure will not be met without the ECMO. And the other criteria is similar. We do not actually exclude Jehovah's Witness from this, but we discuss in detail based on the individual because although it is rare in our region to have a Jehovah's Witness, we did manage a patient with Jehovah's Witness, so we did not exclude these patients. The support for the ECMO program divided into three sections: post-traumatic acute respiratory distress syndrome, which usually in the ICU or after the trauma setup, the management of traumatic tracheobronchial or bronchial injury, and the management of traumatic cardiac injury. And I'm going to give cases and review of our cases that we actually review over the years to illustrate these. For the post-traumatic acute respiratory distress syndrome, we had recently a young female patient who sustained a polytrauma following blunt injury. FAST was positive and her pain X-ray revealed that she most likely had aspiration of wide mediastinum. She went for laparotomy and she was identified to have active bleeding from superior mesenteric artery and vein, which was repaired. The abdomen was kept open, and in the hybrid OR we did a CT scan, and the CT scan can show that she has descending aortic injury and also grade 3 renal injury on top of the superior mesenteric artery and vein injury, and she has also third part of the duodenum which was injured and repaired. The patient was having also a fracture of her ulnar and radius and tibia and fibula also. So based on this, the patient was taken to the ICU, and in the morning she was stented. Post-stenting, she was doing well, extubated, and unfortunately after extubation she required re-intubation because she developed ARDS secondary to aspiration that happened prior to the intubation in the trauma room. The patient was prone but did not work for her, so we activated the ECMO team and her saturation dropped to 51. The patient had simultaneous cannulation of veno-veno ECMO under ultrasound guided percutaneously with maximum respiratory support. Following the placement of the ECMO, the patient saturation picked up to 96, 98, and she actually did quite well with the ECMO. She was trached on the 5th day, and we managed to take her off ECMO and also extubate her without any neurological deficit. The patient recovered quite well and just recently discharged from the hospital without a neurological deficit and for close follow-up. This is to show how actually the saturation improved rapidly as she was connected to the ECMO and resulted in the improvement of higher saturation. So we had published our experience with the outcome of post-traumatic acute respiratory distress syndrome in young patients requiring extracorporeal membrane oxygenation. Total, we had a patient who had ECMO 22 patients, and we compare patient in ECMO versus without ECMO with ARDS. So it is a retrospective study from 2014 to 2020, and we include all the patients who had ARDS based on Berlin definition of hypoxia. And the second outcome measure will include acute kidney injury, hospital length of stay, ICU stay, and ventilation day, and multi-organ failure. So as I said already, we had a total of 85 patients. Non-ECMO group were 63, and ECMO group were 22 patients. The patient in ECMO were younger patients, roughly 30 years, compared to